So now let's talk about the eligibility criteria. And as I've alluded to earlier in another presentation, we think vitamin C will be more effective if administered during that resuscitative phase so that it does tighten up the vasculature, reduce your fluid requirements, and protect your organs a little bit. And so we really want to stress that point, that the early recruitment, early introduction of the study IP is what we're aiming for. We recognize the limitations to being able to, get consent and get pharmacy and get everything going, within 3 to 6 hours. And so obviously you have a longer window, 24-hour window. We didn't want to give you a 72-hour window like we might have with Re-Energize because, it's too late to impact those resuscitative organoprotective strategies. And so you got 24 hours from hospital admission to sort of get things up and running. In many jurisdictions, and it won't be relevant to places in the United States, we are trying to apply for alterations of informed consent. But if you're in the United States, don't worry about it. You'll have to get traditional consent. So get consent from the patient, maybe not likely because of the severity of their illness, or their family member, next of kin, or legally appointed representative. Get consent in those patients who are eligible. So let's go through the inclusion-exclusion criteria. Similar to Re-Energize, we're looking for adults only, 18 years of age older at the time of consent, who have second or third degree burns requiring skin grafting. And here we've simplified things from the days of Re-Energize, where anybody with just 20% or more of a total body surface area are the people that we're interested in recruiting to this. You might have seen an earlier version of the protocol where we started at 25%. We're interested in skewing our recruitment to the right a little bit and just really getting those sicker burn patients who are where resuscitation in large volumes are an issue, where risk of organ injury is an issue, risk of mortality is an issue. So, the not so sick patients are the ones who we're trying to avoid recruiting into this trial. We're at 25% for a couple of years, struggled with enrollment. So now we've modified the proposals, the protocol. So now we're aiming for 20% or thereabouts as the TBSA size to recruit. They're similar to Re-Energize. There's no sort of size for how much is going to be grafted, just that there's an intent to graft them, as that puts them, again, at higher risk of infection and untoward complications. Similar to Re-Energize, there may be, if you're using enzymatic debridement, it may confound or confuse or delay the decision-making around grafting, because you're at day one here within 24 hours trying to say, am I going to graft, yes or no? Oh, let's try enzymatic debridement, and then you don't know until day 3, 4, or whatever, whether you're actually going to graft them. But if on day one, this is a large burn that you would, otherwise have an intention to graft, go ahead and enroll them. Like in Re-Energize, there were a dozen or so patients who never actually got grafted because with enzymatic debridement, it ameliorated the need for grafting. And so that's okay. That's not the patient's still in the trial if they don't get grafted, but if you enroll them with the intention to graft, but you're just waiting or delaying that decision up until later. And again, we can talk more about that in questions and answers. This slide is just trying to highlight the kind of burn injuries we're interested in recruiting and the kind of patients that you may see in your burn unit that we're not interested in recruiting. So the toxic epidermal necrolysis, the Stevens-Johnson syndromes, frostbite, no, that's not patients that we're interested in. And similar to Re-Energize, people who have isolated high voltage injuries that are internal in nature, their resuscitation requirements and trajectory would be different than someone with large surface injuries. If someone with a high voltage electrical injury qualifies on the basis of their surface injuries, that's fine to recruit them. But we're talking here about someone with significant high voltage contact that doesn't meet the cutaneous burn inclusion criteria. We don't want them enrolled. So those are the inclusion criteria. Exclusion criteria is 24 hours. The clock starts when they come to your hospital. Maybe they're in your ED, maybe they're in your burn resuscitation unit. But that's where we're saying, the clock starts, you got 24 hours, try and get them going as soon as possible. But if, it's been more than 24 hours, you haven't been able to get consent, then you'll miss them. And please record that in your screening logs. Similarly, if a patient arrives after 24 hours of injury to your burn unit, maybe they were seen somewhere else and it's a transfer in, whatever the cause of the delay, we think they'll have diminished effectiveness to the vitamin C, so please don't enroll them. Similar to re-energized, patients who are moribund are not expected to survive for, ideally at least a week, if not more. So they get the whole 96 hours of exposure to the intervention. But we know it's hard to judge that in some burns. And so we encourage you to think probabilistically and ask yourself, well, what's the likelihood this person's going to be alive in 72 hours? And if it's a moderate or a high likelihood, then go ahead and enroll. If it's a low likelihood, or you're thinking of withdrawing because of the nature of the patient or their injuries, then please don't enroll them. We know that you're not going to get it right 100% of the time, and that some patients who will get enrolled will die within 72 hours. And that's not the end of the world. That patient's still in the trial. It's just they won't help us answer the study question because they wouldn't have received enough of the vitamin C and had time to manifest a treatment effect. So yeah, trying to avoid those moribund patients from being enrolled in the trial. Patients who are pregnant or lactating are being excluded. Patients who are enrolled in industry-sponsored trials. Now, we allow for co-enrollment in non-industry trials. If it's an observational study where, say, you're involved, investigator-initiated observational trial, you're collecting this and that on your patients, we don't even need to hear about that. It's fine from our point of view that you co-enroll with any observational trial. And we even allow for co-enrollment in other investigator-initiated randomized trials of burn patients. We think, as you know, burn patients are too few to allow them not to be co-enrolled. So if you've got other academic RCTs going on in your unit, we're open to co-enrollment, and we just need a conversation to make sure that the factors being studied in these different trials are not competing or conflicting or interacting with each other. And so in that instance, we just ask for you to send us a copy of the abstract or the protocol so that we can discuss it at the steering committee levels and approve that. And there may be trials that so if there's trials going on in your unit right now, please talk to Maureen about whether we've approved them for co-enrollment, or if you're not sure, send the abstract along and we can let you know. Patients who are already receiving high-dose intravenous vitamin C at the point that you're assessing them will have to be excluded. And we don't think this will be a big issue because most sites participating are not using the vitamin C protocols as of today. Don't worry about someone who comes in with a history of taking vitamin C supplements. Don't worry about the vitamin C that you might be giving in your enteral nutrition or as a parenteral multivite. The levels of vitamin C there are probably less than 1,000 milligrams, so not to worry. It's really, a higher, greater than 1,000 per day intravenously, where you're starting to try and get some therapeutic effect that we're worried about. And so if you're worried about the IV multivite, just send us an email and tell us the dose and the duration, and we can approve that. And here we're excluding people with glucose 6-phosphate dehydrogenase deficiency that we talked about, and a recent history of kidney stones. To be more precise, we should say a recent history of oxalate kidney stones, but people rarely know, why they have kidney stones or from what. And so if they had it 40 years ago, we're not too concerned about it either. But if they've recently had, kidney stones, maybe it's due to oxalic acid. Maybe if we give vitamin C, we could make that worse. Let's just exclude people. And by the way, this hasn't been a major issue so far. So those are the exclusion, the eligibility criteria. Let's stop the recording.